We're welcoming Susan Ford, who is one of the state quality improvement consultants working with the Ohio Perinatal Quality Collaborative. She was the lead QIC neonatal abstinence syndrome project and the Moms Plus program, focusing on improving care for pregnant women with substance use and their infants. Susan is a registered nurse and a pediatric nurse practitioner with over 30 years of experience in maternal child nursing. She received her BSN from the University of Akron and her MSN PNP from Northern Kentucky University. Please join me in welcoming Sue Ford, who's going to talk about the the Ohio Perinatal Quality Collaborative.
Wonderful, thank you. All right, we can go to the next slide. And I have no disclosures. Today, at the end of the session, I'm hopeful that participants will be able to have a better understanding of both the neonatal abstinence syndrome project that OPQC did, as well as the Moms Plus project, looking at those models of care for both. Next slide. All righty. I'd like to start by thanking Dr. Stephanie Weber and the SCOPE project for having me here today. I'm really excited to be able to share the work that OPQC has done. For those of you that don't know, I'd like to give you a little bit of a background. OPQC started in 2007 out of Cincinnati Children's Hospital. Dr. Ed Donovan, a neonatologist there, reached out to Dr. Jay Imes, who is an obstetrician MFM at The Ohio State University, and said, if we're going to really change outcomes in the state of Ohio, we need to go ahead and work together. We need to be able to do this to change outcomes there. So the OPQC started, like I said, back then, and today it consists of all the maternal hospitals in the state of Ohio, as well as all the freestanding children's hospitals. And then in the last year or two, we've also started working with some of the practice offices that aren't necessarily OB/GYN practice offices that aren't necessarily associated or owned by a hospital. So I really feel that our scope is pretty wide. Our mission statement is through the collaborative use of improvement science, which always includes data collection, to reduce preterm births and then also improve maternal and birth outcomes across Ohio as quickly as possible. Let's go to the next slide, please. And we'll start with our neonatal abstinence syndrome project. I was asked to speak about models of care in Ohio. So what I'd like to do is share with you the neonatal abstinence syndrome project that we had, and then move on to the Moms Plus project. We can go to the next slide. So this is a slide of the state of Ohio, and you can see that we had a pretty large participation across the state. The project lasted from 2014 through 2018. And it included all the level 2 and level 3 nurseries in the state, as well as 2 normal newborn nurseries that treat babies with neonatal abstinence syndrome. Most of the babies that are treated in the state of Ohio are treated in the level 2 or level 3 NICUs, but these 2 sites that also participated had a really pretty high percentage of babies with NAS, and worked with OPQC and some of the level 3 sites. Really worked hard to bring them up to speed with treating pharmacologically if they needed to. We can go to the next slide. With OPQC, I think that this is a lot different approach than working in silos or even working within your hospital on a project. I think the greatest thing that I really love about working with OPQC is the collaboration. When we had outreach from the state of Maryland to learn more about our project, one of the lead physicians was saying they really put the C in the OPQC with the collaboration, that they really are willing to share. And I found that not only in the state of Ohio amongst our participating sites, but really across the nation. The benefit of being a perinatal quality collaborative is really the ability to reach out to others across the United States and learn what are they doing in Illinois, what can we learn from what's going on in California or Florida. And I think that I have really benefited from that, and I think our teams have also. This all teach, all learn concept that I have up here on the screen is really embodied by the collaborative, and the ability to learn from others and also share what has worked at your institution, what hasn't worked at your institution, I think is really powerful and accelerates change and outcomes. We can go to the next slide. So how do we accomplish our aim? And for this project, the Neonatal Abstinence Center project, our model really focused on standardization. So I'll talk a little bit more about the standardization of the care plan, the treatment plan for the baby, which included both a pharmacological and a non-pharmacological approach, as well as standardizing how to identify the babies with NAS and also to treat them. And then also the other side, which wasn't so easy to measure, was creating a culture of compassion, understanding, and healing for that maternal infant dyad, really trying to decrease stigma there and improve attitudes. And you can go ahead and be objective in your length of stay, of your length of treatment, and follow data like that. But I'm going to talk a little bit more later about the challenges of trying to measure an attitude. So we can go to the next slide. One of the standardizations that we did was to make certain all the participating sites in the state were using the same scoring tool. So when an infant has been substance exposed and is born, you want to go ahead and do a scale to see if this baby is going to require treatment. There was a lot of variability amongst not only the state, but really within the hospitals themselves. There are many different iterations of what is called the Finnegan scoring system, which is used across the nation. And we were able to get some training and from a site that does this out of Vanderbilt, and really go ahead and make certain that everybody was starting at the same understanding of what the scoring system was. I also want to talk a little bit about inter-rater reliability, which means the nurse at the bedside, let's just say bedside number 7, would get the same number as the nurse at bedside number 8, number 9, so that there is consistency there, and that within the scoring tool here, that 90% of the answers and the number that the nurse came up with were the same. We could go to the next slide. We also standardized the pharmacological treatment bundle. This grew from the Ohio Children's Hospital Association project. That was a pilot study that was in 2012 to 2014. And they worked with the freestanding children's hospitals and their affiliates in Ohio. This was funded by the governor's office. Governor Kasich really wanted to standardize care and have all the hospitals work together on some quality improvement project. And they selected NAS. They went ahead and found that they came up with this protocol, and you were allowed to use either morphine or methadone. They didn't stipulate you had to use one or the other. Each site was allowed to choose which drug of choice they wanted to treat with. But then there was an algorithm and a treatment bundle that was followed. And because of the great decrease in the length of stay, Medicaid asked OPQC to spread this throughout the state. So this was our starting board. You can go to the next slide. And then I think this is really important, the non-pharmacological treatment, perhaps even more important than the pharm treatment, because this is what starts, what you initially start with. And decreased stimulation, rooming in for mom and baby, swaddling, skin to skin, and big push for breastfeeding. We really advocated that and had teams look at their breastfeeding policies and protocols for moms that were in MAT. And really found it to be very helpful, promoting bonding, and the literature shows that very little MAT medication gets in the breast milk, and that it also might be a bit of a help and possibly reduce the length of stay for the babies that are in the NICU being treated. We can go to the next slide. We also did an arm of the project that was called orchestrated testing. Each of the sites were self-selected into a group to test different formulas if mom wasn't going to breastfeed. And we tested over a period of a year to see which formulas seemed to show the best outcomes for the baby. And we found that 22-calorie formula was associated with less treatment failure and a shorter length of stay for these babies. getting them home earlier with their mom. The benefit of the low lactose formula was not consistent across all outcome measures, but there did seem to be a possible synergistic effect if that was used in conjunction with that 22 calorie on weight loss and on length of stay, but it didn't seem to impact treatment failure at all. So this was an area that really garnished a lot of excitement and really was something that teams embraced to work on to try and find what might be the best formula for NAS infants that were not being breastfed. And we can go to the next slide. The project also focused on partnering with other stakeholders to influence policy and primary prevention. Back then, Governor Kasich had Neonatal Abstinence Awareness Week. We also put together various marketing tools for both providers and patients. Those are available on our website there at opqc.net. We can go to the next slide. And this was the improving recognition and non-judgmental support for women with substance use disorder and their infants. And like I said earlier, it was a bit more challenging to try and change attitudes. We had a survey that came out of Australia that we received from VON, the Vermont Oxford Network, and we sent it to our participating sites for all the staff in the NICU units or the two newborn nurseries to have them complete it to see what their baseline scores were, and then throughout the project if they improved. And when we first started talking about this project, I'll tell a little story here with just the impact to me of what I realized we needed to do a lot of work. We were on a call talking about the benefits of breastfeeding. And there was a neonatologist that spoke up and posed a question, and he said, I just don't understand why we're encouraging this. I really think that the only reason these moms even attempt to breastfeed is to look better to children's services. And I thought, wow, we have a lot of work to do with attitude improvement. So I do think that, again, it is challenging to measure. And this survey that came out with this training resource from Australia with attitudes towards opioid use really, I think, was helpful to us. On the next slide, I can show you what we did to try and some of the points we did to try and improve attitudes. Vermont Oxford Network put together a wonderful video, Nurture the Mother, Nurture the Child, and it comes out of British Columbia, where there is a program there that is a total harm reduction. I don't know that it would be embraced totally in the United States, but just very eye-opening, really thoughtful and provocative video that all the sites received. We also, on our learning session, in one of our learning sessions, we had a panel of patients that had lived experience either as a mom with OUD and who had an infant with NAS, and we also had an adoptive mother of a baby with NAS. And I think that might have been the most powerful impact to our attitude change. Just meeting these women, listening to them, talking with them. I think that was very, very impactful. I think that ingraining education that addiction is a chronic disease similar to diabetes, relapses happen. I think that ingraining that into any model of care is very important. And lastly, we did something with community resource outreach, which this was, again, a favorite part of the project. We challenged teams to come to the learning session after reaching out to a community resource in their area that supported the mother-infant dyad to learn more about it and come report out on their storyboard at the learning session. And my favorite success for this is about a team that was in the southeast area of the state. And they reached out to a recovery group. I think it was a housing for pregnant women with OUD. And they came there to talk about NAS. This is what happens at delivery. This is what we're looking for. They went over that Finnegan scoring tool. This is what you can expect and with your labor, your delivery, and your postpartum period. And one of the moms asked a question, and she said, could I possibly have a tour of the facility? Could we go and see the labor and delivery? Could we see the nursery? Would I be able to do that? And she said, oh, of course. It's the third Wednesday of every month, and you can sign up online. And if you don't have computer access, please call the unit. We'd be happy to have you. And here's the heartbreaking part. She said, I don't think I would be comfortable in that setting. I think that I wouldn't feel with all the normal moms. I wouldn't feel right there. And this nursing director said, well, how about if we have the group come and do a group prenatal tour for all of you? And everybody was so excited about that. They went ahead and did that, and they had such success. It was a win-win for the nursing staff. It was a win for the patients, that they do it every month now. And the feedback has been tremendous, and they really feel that it is helpful for across the spectrum there, and they have adopted that into their model there. Let's go ahead to the next slide. We also have a guide for families about neonatal abstinence syndrome. This is something that has been requested from all of our participating sites. Many of them share it with their families. We've also had a lot of national interest in it. It's available on our website for download for anyone who's interested at opqc.net. And we could go to the next slide, Andrea. The other recommendation here that came out of our project, at the end of the project, we went ahead with a pretty robust data analysis to see, we went with this initial protocol for pharmacological care, and did we need to change it? So looking at data analysis of over 6,800 babies, we did update the protocol for those that were using methadone in their unit. That was updated. That resulted in a shorter length of stay with the algorithm that they used. And then we also changed the initiation of treatment. So how soon do you start that morphine or methadone after those scores start escalating? And then lastly, the morphine escalation doses, they were changed to be more dose dependent. And so almost like a sliding scale for insulin. If this is your number, this is what you treat with. If this is your number, this is what you treat with. So those were the changes to the pharmacological treatment. And then with the non-pharm, like I said, all babies were treated with the decreased stimulation, continuous holding, frequent feedings that would be breastfeeding if mom is in a treatment program, and if not, or if mom chooses not to breastfeed, that 22-calorie formula was really ideal. And then if we look at the next slide, many of you, I'm sure, have heard about Eat, Sleep, Console. This was coming out around the time our project was ending. This came out of Yale with Dr. Matt Grossman. This model for NAS treatment focuses on comfort care. It maximizes the non-pharmacological bundle, which is increasing maternal input, family intervention in treatment, and then also instead of the regimented sliding scale or algorithm for the treatment protocol for morphine, it was PRN, or as needed doses. And this also looked at decreasing the length of stay and having that baby with mom markedly more so. In Ohio, there are some sites that have changed to this model and are using it. I did speak with one site that actually uses both, kind of a hybrid approach. They'll use the Finnegan scoring, but then they'll go with Eat, Sleep, Console for the medication route. And then we also have several of our sites in Ohio that are starting this NIH study with the Neonatal Research Network and the Pediatric Clinical Trials Network. It's a randomized study to compare the Eat, Sleep, Console model with the model that we're using in Ohio. And it's not just the state of Ohio. I want to say there are numerous other states participating. I did reach out to a couple of our lead neonatologists at the NICUs that participated in this project to see if there's any early data, and it sounds like there was a slower start due to COVID, and that it's too early for data. They're just starting to get into the protocols and looking at the best way to approach this. So stay tuned. We're hopeful to see results of this and learn more. So let's go to the next slide, and I want to transition now to maternal care, away from the infant, and talk about maternal care. In Ohio, we started with the NAS project, and we decided at the end of it, well, where do we go from here? And let's go upstream. Let's get to the mom while she is pregnant. We can go to the next slide. The Maternal Opiate Medical Support Project started, and this was 25 partner sites with 4 faculty mentor sites, kind of like a hub-spoke model. And this was, the aim was to improve collaboration amongst all the providers who care for the mom while she's pregnant with OUD. So that's the obstetrician, the MAT provider, and the behavioral health provider. And then we also wanted to support that maternal infant dyad post-delivery, but really the greater focus of this project was more on that collaborative piece. We can go to the next slide. I point out this slide. This is the participating sites across Ohio. You can see that they're really regionally focused here. And I'm talking with my hands, I don't know if you can see, but they're regionally focused, where you've got Northeast Ohio, Southwest Ohio, Central, and some in the Southeast as well. And we found that, and this won't surprise anybody, that the opportunities and the resources that were available and the challenges really differed region to region. So this approach was a little bit different, as where it was statewide, it was specific within regions and districts there. Let's go to the next slide. And so the models of care for the MOMS project, I identified 4 essentially. The first is the co-located model, and this model is when the care is kind of one-stop shopping. And some of our faculty are buprenorphine certified. They're able to prescribe buprenorphine, and some are even addiction specialists, where they can care for the mom for detox and go ahead, and with that co-location, they're able to provide both the MAT, the medication assisted treatment for mom, as well as the prenatal care. The coordinated model is a little different, and it also obviously differs between the urban and the rural setting. The coordinated model has the MAT provider in a collaborative relationship with the MAT provider, but it's outside of their system. So mom is going to the OB for her prenatal care. She's going to a specific behavioral health and MAT provider outside of the system, but there is collaboration amongst those providers in their care. And then the residential model, there are 2 great examples, Mary Haven in Central Ohio, and First Step Home in Cincinnati. Also, First Step Home participated with Dr. Marcotte, medical director there, as one of the faculty. And the residential model is in residential treatment while also receiving their prenatal care. So they're able to receive all that in a residential setting. And First Step Home also allows the infant, the baby, to stay with mom there postpartum as well, which is really a bonus. And then lastly, I think for those of you that don't know what centering is, it's similar to a group prenatal appointment. And it's very popular in many settings. What is unique to this project is that the centering model was specific for mom with OUD. And there are 2 models like this in the state of Ohio. One is in Northeast Ohio at SUMA, and the other is in the central to southeast region there at Adena Regional. And both of these projects, really the feedback, I've spoken with patients at both of those groups, and just the wraparound services around there with the centering model also is amazing. So very different models of care here, but all within the same focus of coordinated care for the mom with OUD while she is pregnant. And I do want to throw in here also that several of these models do include postpartum support, education, follow-up, sometimes up to a full year after the baby is born. So this, I think, there's definitely room for improvement there, and lots of opportunity for continued support within that first year postpartum. Okay. We can go to the next slide. Briefly about our, I don't want to take too much time here, so we keep to Andrea's schedule. The Pocket Guide is a screening tool that ACOG recommends all moms who are pregnant be screened for substance use disorder. And we had all of our sites select a validated tool to screen. There's a big difference between screening using a questionnaire versus using a drug screen. So this was something that we did recommend, and then also is available on our website with thanks to Oregon for, we were able to steal shamelessly from them. And then the next slide, we also have an OUD checklist for the mom with OUD during her pregnancy that also is available on our website, and several of our sites participated in use of that and improving that and gave feedback for that as well. And on our next slide, I want to talk very briefly about the plan of safe care, and I think that this is a good transition when we talk about the need to continue this work on postpartum to support that maternal infant dyad. And this starts in the pregnancy with making certain that mom has the supports she needs and that it's documented. So when the plan of safe care is put together and created, it's clear to the state and to Children's Services that there are supports in place and that the baby will be going to a safe environment. Ohio is really fortunate under the direction of Dr. Rick Masadi from Mental Health and Addiction Services. He applied to have Ohio be part of the National Center of Substance Abuse and Child Welfare to participate in their Practice and Policy Academy, and Ohio was selected as one of the states. And you can see from this slide here, we have so many different services here. We have Job and Family Services, developmental delays. We have the Supreme Court of Ohio, ODH, ODM, really OPQC is very privileged to be able to learn along with this organization and all of the support of everybody participating in this. On the next slide, our work is, our Moms Plus project was paused with COVID, and we're looking forward to moving forward with an ODM sponsored project where we will be focusing more on that postpartum aspect of maintaining that maternal infant dyad and what kind of support exists to nurture the mother and nurture the baby. And so the next slide, I just want to say again, and I feel like this is preaching to the choir for all those on the call, that it really does take a village, and we're so grateful at OPQC for all the support of our shareholders and stakeholders. It's really all hands on board to support moms with OUD and their babies, whether or not they have a need for treatment with NAS. And I think that really these models of care, just continuing to investigate them and to improve on them is something that we can all strive for. Okay. Thanks, Andrea.
Thank you so much, Susan. So much incredible work. It's great to just see how you were able to pull together the state to really create change and just kind of keep moving the field forward, for sure. I want to open it up just to see who has questions for Susan. Feel free, you can either type them in the chat or you're welcome to unmute yourself.
So I had a clarifying question about the attitudes. Could you talk a little bit more about like the findings of where people were in general, like the caliber of where attitudes were, and then whether there was any type of difference as a result of participation?
Sure, thanks for the question, Michelle. Again, it's very hard to take something so subjective as an attitude and try to validate it and have it, what is the meaning of the improvement to make it as objective as possible. And I'm really grateful for the data analysts that we have at OPQC that were able to do that. I'm happy to follow up also. We did a manuscript, and it is in a stage of review right now. So I'm hopeful that it will be published. And I'm happy to follow up with some graphs as well that we have for those studies. What I can share is that there were 7 questions that we asked, and they were related to deservedness of care and the impact that the individual themselves had on their own disease. And initially, probably overwhelmingly, the scores were the highest for those that they deserved medical care, which I don't think is that surprising for medical professionals. You're hopeful that those would be high. I think that the impact, the greatest impact we saw was those that felt that it was a choice that they didn't really have, that they were making the choice to be like this, or to use illicit substances. And I think that was probably where we saw our greatest improvement, and hopeful that, again, those parameters that we used, we leveraged to try and get that point across, with it being the patient panel, with it being the addiction specialists talking about it as a chronic disease instead of a moral failing. I think that those probably are items that impacted the most.
Thank you, I appreciate that.
Sure.
Stacy, I was wondering if behavioral health support is offered to women with OUD or SUD in the hospital. I've noticed that often women get pretty anxious in the hospital, and I haven't really seen much support that way for women. They're worried about the baby, and they get more and more anxious, and I think that might be a helpful thing.
That's a great question, Stacy. And my reply to it would be that it varies across the state. I think there are some sites that had very robust, and usually those are larger institutions also, that had the ability to have behavioral health or MAT that included that. Whereas I think some of the smaller sites struggled to find that. When we found the pockets throughout the state, there were some that had no behavioral health within several miles. I think that telehealth is helpful, but specific to the acute setting that you mentioned in the hospital, I don't know if that would be as available. I know that, just with COVID, the telehealth obviously has really grown, as has the ability to reach some of the restrictions and such around that, I think have really helped during COVID. And I think that that's an opportunity that we really need to investigate and include as we're working with the moms.
Thanks.
Thank you.
I wondered, Susan, your group has done such a great job working at how to care for the infants in the hospital and thinking about moms and supporting, moms postnatally. I'm wondering, what type of training and education do the moms and or other caregivers that are bringing the babies then home from the hospital, has your group worked as far as standardizing the information that the parent, the mom, the parent, the caregivers are getting about neonatal abstinence syndrome and care after they leave the hospital?
Good question, Andrea. I think that the project, like I said, went from 2014 to 2018, and during that time period, we did put together that booklet. That booklet is available on our website. That being said, it's not the deep dive that the hands-on that you need. I do know that I want to say it's Job and Family Services. Rhonda Johnson is someone that does training across the state for NAS foster parents, and I think that is very important. I think that the babies going home, post-discharge, there are some issues that are needed, and follow-up is needed. There are some great NAS follow-up clinics in the state, and I know Dr. Rettig is on the call, and also was instrumental with her NAS clinic. I know there's one, Cincinnati Children's, Columbus Nationwide Children's, and at OU, Ohio University in Athens also has an NAS-specific follow-up clinic, and I think that those are great supports for education and also for making certain that developmental milestones are being met. Is there strabismus, an issue with the eye that is something that is found often in infants with NAS? So I think that having the ability for someone who is aware of issues and able to support the family, whether it is the custodial parents or the foster family, I think is really important. And I look forward to this project that we're going to be starting, this at the end of this year with ODM, because I think there are a lot of opportunities around that. I'd be interested, Dr. Wettig, do you have any thoughts on that with the follow-up?
I think that statewide, what some of the initiatives we've done from Cincinnati, Dr. McAllister and her group and I all work together at the NAS clinic at Children's, educating the Help Me Grow workers to what is specific to NAS. I recently spoke to the early Head Start workers in this area. So I think that it's important that those people who can really get into the homes have a sense of what drug exposure means, and they can be the ones who can be educating the parents in real time. I think it's important definitely very important for foster parents to be aware of whether or not a child in their care has been exposed in utero, which is sometimes more difficult to know than whether they had NAS, because with NAS with treatment, they're obviously picking them up from the hospital after they've been there for a while. So I think that, yes, it's important to have the pamphlets that we have through OPQC, but I think it's also important that people who are going to the homes and see it in real time and say to the parents in real time, yes, this is what you can do when your child is doing this and this, because from our previous sessions with the sensory therapies and the speech therapies, we know that maybe, unfortunately, but most of these children actually present with their difficulties later. They're not so proximate to coming home from the hospital. And so we need people who are going into the homes to be aware that that's what's going on.
Yeah, I think that's a great point, Dr. Wettig. Thanks for speaking about that. And I'm also thinking too, just going home from the hospital, parents are so overwhelmed and with so many things that having the folks that are in the home to just walk them through things in real time makes so much sense, which will lead us well into our conversation a little bit. Other questions for Susan or Dr. Wettig?
Andrea, I see in the chat box that Sue Meeks has asked if pediatricians are being trained to monitor children for developmental issues after they go home. And I can tell you from the standpoint of what's happening at university hospitals with Rainbow Babies and Children's that includes, training with the residents for the discharge and such in the NICU or the step-down unit at Rainbow. The AAP also has some trainings available as well. But again, and not to keep picking on you, Dr. Wettig, but perhaps, is there anything from the developmental standpoint for training pediatricians that you know of other than AAP or within their own institution if they're hospital-based?
At this point in time, no, I don't really know of anything. And I can particularly say that because our residency program actually reached out to us at First Step Home to have a rotation for the residents at First Step Home, which we set up. It was all ready to start and COVID hit. So we did not get to initiate it this year. But so I know that, yes, residents who are actually in the thick of this are asking for it. Just to put this in perspective, I was 25 years a neonatologist before I really had to handle neonatal abstinence syndrome. So That's, you know, about 10 years ago. So pediatricians really, really haven't had a lot of time to educate themselves to what they're seeing in their populations. That being said, there's a lot more. Every conference will have somebody trying to speak on, or is speaking on in utero drug exposure or NAS. So yes, that's an area we really need to work on, Susan.
Yeah, I know that. I hear a lot of parents say, or others, that the baby maybe didn't have NAS, but we know there was exposure, and often even when they did. And talk to them a little bit about, you know, watching for things that may come up. And what I'm hearing from parents is the pediatrician says they're fine. And I think in that moment, they may be fine. But I don't think anyone's monitoring for, you know, physical therapy or speech or those kind of things. And, you know, I'm trying to get together something that actually gives that information to parents at this age. You know, it might be a good idea too, because the pediatricians at this point are not providing that. And parents assume everything is now fine. And it may stay fine and it may not stay fine.
I totally agree with what Dr. Wedding and Sue said. It's an area that needs a lot of work. I think it's complicated too by some of these kids may go home with birth mom and then they're in relative care and then they may end up in foster care. So they may, and unfortunately their medical care often transfers at that point. The foster parent may not choose to take them to the same pediatrician they were seeing before. If they go to another relative, it may be in a different county or in a different area. And again, they may choose a different family physician or a different pediatrician. And that just further complicates the information being passed along so that the provider is aware of the background and what to watch for.
That's why I think it's so important that the children are in Help Me Grow or Early Head Start. And I can't do more than to encourage our home visitors to really step up when they have concerns. Now, I know in Hamilton County that when a child's in custody, they are referred to Help Me Grow. I'm very happy that Help Me Grow has accepted NAS, whether treated or not treated, but a child who's been exposed and shows signs of withdrawal. They've accepted that as a qualifying diagnosis. So it gets kids in the door for that. So I think we just need to really encourage those type of services for any of the children that we see. Because I agree that they move from pediatrician to pediatrician. Pediatricians have what, 10 minutes maybe with a child in the office. And I will tell you, many of the kids that I see and the parents come in with this like horrible behavioral story at home, they are so cute in the office. They do everything I ask them to do. It's like you take your child to the doctor and they're no longer sick. So we need somebody who's seeing it more real time.
I think as you guys are talking, it makes me really think about the role of our CPS and foster care system in having to kind of bridge the information. So making sure that everyone involved in the care of these kiddos is getting the same consistent information about that kiddo. And I know that's a challenge nationally with any CPS or Child Protective Services. Sorry, I'm using an acronym. But it does make me think like if there was a resource that we could be sharing to kind of include them and get those folks trained so that then they're consistent, you know, with bio families and with foster families and kinship care, that might be where we get the biggest bang for our buck.
So many great thoughts, and I've been like hesitant because we're scheduled to go to breakout rooms at 10:15, but there's been such great conversation. I wanted to let it go, but I do think, and I was sitting here wrestling with myself, do we want to just keep going or go to breakout rooms? But I think, why don't we plan just for 10 minutes to just break out into our groups that we've been in throughout this and process this a little bit. And I think it would be helpful too. We've heard some things, you know, resources for CPS, home visiting, Head Start, Help Me Grow, you know, thinking in our different groups and in our smaller groups, what do you see your role in this? What do you see as some strengths? What do you see as those barriers? And then we can all come back as a group and kind of unpack that a little bit more. Does that sound like a good plan for everyone? Okay, great. All right, well then Jessie is gonna go ahead and send us to all of our breakout rooms. Welcome back, everybody. Clearly our group we had lots to chat about. I'm sure that all of you did as well. And I would love to hear from you all and thoughts that you had about, you know, needs for the model, what a model could look like, all of those pieces, and see if it's similar to what we talked about in our group. So I don't know who would like to share discussion.
I can share. Our group talked about some strengths being some of the academic centers and things like the SCOPE project with strong NAS clinics in some of the academic centers and good follow-up clinics established there. The foster system being strong with great foster parents. And then the Help Me Grow handoff with the qualifying diagnosis of NAS being a strength. We talked about some barriers around sometimes not knowing the exposure status, so that either being suspected but unknown, and difficulty with paperwork, following kids from one place to another, and the need for standardized guidelines for evaluation and follow-up of these kids. And that was really one of the big things, and probably like a step moving forward from our group was kind of guidelines for how to manage these kids.
I like that. That's a nice actionable step, that need for a standardized evaluation. And that maybe that plays a little bit into what we were talking about in our group. We were just saying that it was Barb that was telling us, you know, she's in the NAS follow-up clinic, and like, how much do we talk to parents about at that point when we're not quite sure? And so I think that's where those a standardized set of assessments would be so fabulous, right? Because it could be kind of, as we know at certain ages, we're starting to see patterns of when some of those difficulties arise. Having some of that, if we could map that onto a standardized assessment and evaluation protocol, that could be very powerful, I think, going forward. You know, and I'm going to draw parallels, and then I promise I'll let other people talk. It's like my tendency that I want to just tell you everything we talked about too. But you know, we talked about, you know, that's great that Help Me Grow has that standard diagnosis, but we were hearing a little bit of some challenges between Child Protective Services in them handing off to Help Me Grow, and that there's been some experience with some folks that Child Protective Services may not really understand what Help Me Grow has to offer in a way that they're able to educate families and provide that warm handoff. And so I think kind of looking at that, the systems of care, I think we heard from you guys the transition, and how the transition from one service to another is an area, so we always know that's right, the same thing that happens in disability, it's an area where we lose people through the cracks. But what is some way that we could kind of standardize that flow from different systems in a way, and educate all of the different systems on everyone else? Other than ECHO, they should all come to ECHO, right? That's the answer. Okay, what do other people think? Or what else did you all talk about, other recommendations?
Our group talked about relationship building in a lot of capacities, relationship building with pediatricians. Melinda talked about how since pediatricians have such a short window, if parents aren't familiar with some of the late onset issues, they might not even know really what to ask. And so someone coming to the home, like a home visitor, could provide some awareness, and could also help reduce some of the stigma and maybe buffer some of the grief they may be feeling. Having trauma-informed care resources for all of the different systems is helpful. And we talked about helping unpack what some of the occupations do. We talked about how a lot of people don't know at all what OT does, and that's something that could be explained long before same thing with speech language pathology and other PC like that, so that before the child is even born, in some cases, parents can have an idea of what some of those things are. Also talking about how if parents could be educated to understand that pediatrician is to be an advocate and source of support for them, they may be less likely to flip and change providers and do those things that result in less continuity of care. And educating child care providers on some of the benefits of OT, speech, things like that. And educating foster parents on the variety of supports there are for those children.
Great, so many fabulous ideas. Yeah, that relationship building piece seems so huge, and education, like, yeah, I think, and trauma, so many important topics. How about others?
So our group talked about the need for birth parents to remain involved with what's going on with their children, particularly if it's Help Me Grow or other therapies that they're receiving. If the goal is reunification, then the birth parent should be involved, because when that transition occurs, they may not even be totally aware of all the issues that the child has been working with, and so they lose out on their therapies. Or they may be even belligerent and say, he never acts this way when he's with me, so that's not a problem. So that if early on, if there's still a strong goal for reunification, that that different situations be available to the birth parent, so they are more aware of what's going on. And then the discussion about a kind of a laid out plan, we do at our drug exposed NAS clinics have kind of a care plan that is for every child, when we see them for what different things. So if that's ever helpful, we could make that available. I mean, it's just our plan from Cincinnati, but it at least brings kids in at particular times, does sensory testing, does behavioral testing, does medical testing, based on the age of the child, at least up to age 3.
I think that sounds like a powerful thing that you guys have. That would be great to share. I think that's a fabulous point of keeping those birth parents involved. That one of the themes we've heard, right, is that continuity of care and information, right? Holding on to that information. That would be a great way if reunification is the goal. But others?
I know our group kind of expressed some concerns that a lot of the kids with NAS behavioral issues that show up later on. And so, what do we do about kids that are in elementary school and middle school that have kind of fallen off the, hey, this was an NAS kid. What can we do about that? Also, talking about the fact that a lot of the home visiting programs drop off at age 3. So then it's kind of what we were just talking about, continuity. How do we continue to have that support for parents? So that kind of all adds up, building attachments, teaching parents how to read children's clues and that kind of thing.
Right, as they go on. And that was something that Barb talked about in our group. She's now in a high school setting and was saying that, there's maybe not always this tendency to look all the way back to birth records by the time kids get older, and there still can be, sequelae related to that. I've lost count of if all of the groups have reported out or not. Sorry.
Andrea,
things to talk about. Perfect.
Andrea, I can tell you a little bit about what our group talked about. We had someone who shared that there are some wonderful programs that exist and are doing a great job. One of those being Pathways, which is I think was a piece of Help Me Grow that follows pregnant moms and educates them. we also identified some areas where, some needs too. And so we talked about interdisciplinary education of professionals is an area that is needed. And so these echo sessions are fabulous for that. But we were thinking of, what other ways can we all learn about the effects and how best to support the families. And then we talked about the need for childcare for children who have behavioral difficulties in general, I guess, and developmental disabilities. And then perhaps there's just just some personal things, but the need also for parental support too, and connection with other parents, birth parents, foster parents, or anyone caring for children who have NAS, so that you don't feel so isolated and alone and have that time for self-care.
Great points.
I know we didn't talk about this, but I think it's important and worth mentioning that there are barriers within like foster care that make it hard to share information consistently with birth families. The one thing that comes up for me is a lot of times parents are asked to work through their case plan, and if they're not making, it's kind of like they have to show themselves before they get information on their kid. It's almost like a carrot that's dangling in front of their face, which, I value that. You want to see parents making a good investment and doing what they need to do. But inevitably what ends up happening is it's like, we're not giving them information, and then all of a sudden they do what they're supposed to do, and then it's like, great, we can give them back to you now. And there's no place in that plan to make sure that parents are getting all the information that they need. And so that's making me think that we could do some advocacy with the foster care systems around what we need, making sure that that's part of the plan, is that families get consistent information.
What I'm hearing, it sounds like when we do our echo next year, and from a lot of you, is that maybe Child Protective Services and the foster care system should be a target that we should bring to our interdisciplinary team. I think we've had a fabulous group of all of you with your different disciplines, but I think that seems like that might be a win. Because it sounds what I'm hearing from a lot of folks is that it's they've got so much they're dealing with, but yeah, if we could get some advocates and some that just kind of understand those pieces, that could help with some of those barriers. Any other thoughts or reactions? So I've been reacting as everybody's been sharing their ideas. What else do you think? People who are in other groups, were there things that resonated with you that you wanted to echo? Some common themes, other things you were burning, you wanted to say but hadn't had a chance to say yet?
I think one of the things that kept coming up over and over was just the power of relationships to help build resilience, both in the child and in the family. So in thinking about the transfer from children's services to the foster system and withholding information, and then, like Michelle said, just getting it all at once, kind of works against that, because if a child has been in some kind of therapy with an OT or a speech therapist, but the parents have not been involved, and all of a sudden they have custody, well, their child may have a relationship with that service provider, but they don't. And that could have maybe been mitigated somewhat if they had been at least a little involved during that whole process prior to reunification.
And maybe invest them a bit more in the care. If that, it's hard if you've not seen any of the growth. Yeah, Melissa or Michelle's loving what you're saying, Melinda. But yeah, what a great point.
I'll say something really quick as far as, because of Zoom, we had a family recently where we were able to get the foster parent on the video call with the child and do like the evaluation and assessment appointments, and then have bio mom in a different area, like on the video call in a different area. And I was like, that's like because of technology, we would have never even thought about doing that like before. So I was like, every single time from here on out, like we will definitely have to see if we can't do something like that. Or like you all said, even if they can't do that, because, you know, sometimes you can see kind of where people are by just being there, but even just having appointments where the provider is able to talk to them on the phone or something like that.
What a great point. What, you know, there are some silver linings to everything we're going through right now, but what a great, thanks Alicia for sharing that. I think that is a great way to illustrate just a little, you know, and just zooming, you know, especially now most providers, we've been kind of forced to figure out how to do telehealth on some level. So we know what's HIPAA compliant. We know all of those pieces. So if we just schedule that FaceTime in, and then it's the barriers to transportation and some of these other issues that come up, we take those away to have the bio parent join as well. Great point. If you're going to come back in the fall, next fall, you should use it as a case for us, Alicia, and you should present that next year for us, because that sounds like a really cool case. All right, I'm looking at the time and we're coming up. Any last thoughts or other things, illustrations like Alicia just shared with us?
Sorry, I feel like I'm talking a lot today.
Love it.
Yeah. So I love that Alicia brought that up of having these having everybody at the table. I think this also brings in the point of having really good trauma-informed care providers, because kids are going to be at different levels of reaction, right? Like, and having somebody at the table who can kind of speak to like maybe why a child might be reacting the way they are through a trauma lens would be helpful in building those relationships and kind of starting those foundations. I think sometimes what happens is when you don't have someone who is trauma informed to kind of help navigate these situations, you end up having evidence to say that like, oh, you know, bio mom shouldn't be involved because look how the kid reacted, or like, oh, this isn't a good fit because that, you know, like from a bio family perspective, like my kid's not reacting right, and you know, maybe it must be something with the foster parent. So I just think, you know, as we start to move in this direction, we've got to be really mindful of what we're doing.
It's a really good point, Michelle. Thanks for framing it within that. Oh, and I see, so Melissa is sharing in the chat. She says, we need more education for our school-age speech and language pathologists and OTs and how they can support staff members and children in the school setting. Funding to increase, the number of SLPs, OTs, and OTAs to work with students who have NAS and other conditions. Agree. Often the focus is limited, to these really concrete things, right? Like articulation for SLP, fine motor for OTs, and those social communication and sensory motor issues are overlooked, put aside. Had a kid in clinic yesterday. They didn't see the need for social communication support. We're gonna knock them over the head with lots of documentation and hope we help. But I think some of it is funding too, right? So, and education, and the support can help teachers and administrators understand children's needs and strategies to help them, rather than just providing consequences for behavior. Yes, our early childhood team is so much more whole child focused and collaborative than school-age teams. That is such a good point. I was talking with another early childhood preschool team who was saying the same thing, that the preschool teams just kind of they're integrated on that level, and how can we move that into the school-age level? I think that's a whole other echo we could do for our school-age and high school. Looking at Barb. Barb's like right on my screen because she's in my groups. To just keep that continuity of support for everyone going forward. Thank you so much for sharing that, Melissa.
Can I speak for just a moment about the OT portion of that in schools? I did a little tiny bit of work in the schools a long time ago, and I left because my push to do more was pushed against. I was very much put in a box in what I was allowed to do and what I could do there, and it just didn't, it just didn't fit with me. And I think that OTs in general, we need to support one another and educate, how do we get past that? Because it wasn't me, it wasn't my work, it was the administration saying, you know, we're paying for you to do this thing and that's it. And so, you know, when I do talk to other OTs that are working in the school systems, you know, they're very hesitant to move outside of their predetermined box by their administrators.
That's a great point, Kathy. Can I ask a follow-up question to that? What do you think is needed to change that?
I'm not really sure. I'd like to pose that question to other folks. You know, I've worked with other OTs and, you know, they're just not always comfortable pushing against the norm. So I'm not sure. There was a movement maybe more than 5 years ago through Ohio called Every Moment Counts. And that was where a whole bunch of OTs across the state did some work together to do like primary services, secondary services, and tertiary services so that you could create programming within the school setting that hit all of the kids, not just, you know, the particular kid in your classroom. You know, I'm not sure where that is now because I'm not in the school system anymore. So that's something that maybe we could look at.
Interesting. Looking at time. Oh, sorry. Someone else has something to say.
It was me. I've seen that reflection too, Kathy, from the speech perspective. I've had people say, Barb, stay in your lane. And so that whole, I came from a collaborative background in preschool. So that whole piece of collaborating, like we've got to get kids graduated and get them moving on. And so that whole piece of, you know, time is a huge issue with therapy and, but you have to make that time for the collaboration. But I've had it many times, like, stay in your lane, Barb. We're not talking about that piece of transition yet. But it's like, we have to be integrating all of that care to get to optimize the outcomes for our students and their families. But I don't think that our system lends itself to that very well.
I think schools are, the major concern in schools and the administration is behavior. Children who don't behave well in school are big problems. So if there's a way to tailor what you can do to change behavior or improve behavior, that's probably going to be the strong point to take to any administration. We can improve behavior by, because that's what we hear from the schools. Behavior is the biggest problem with these kids or other kids.
That's a really good point. Find what is meaningful to them. That expulsion and all of those pieces.
And Sue, I'll add to that, and I'll be really quick, Andrea, because I know we're trying to close, but I'll add to that too that, you know, it's interesting because administrations, their approach to behavior is often not trauma sensitive. And so, you know, educating about, you know, the acting out cycle and recognizing triggers before they happen, all of those things are like, it's like so critical. And so I would argue, you know, behavior can improve and we can help children, you know, through their trauma around whatever. So
true.
That takes longer than many schools are willing to invest, which I think is what you end up running up against. I agree with you though.
Yeah, it is. You got these funding constraints, time constraints, all of these pieces. Well, it sounds like we have more work to do. And I also am wondering if next time around, so we now have only 5
I think one of the big issues too.
Oh, sorry, go ahead.
I was just saying, I think one of the big issues too is that our kids look like every other child. These challenges are invisible. So if
oh no, Melinda froze.
they had antlers, people would adjust to help them if they're big for their age too. But they look like other kids and they don't act like other kids, and that works against them.
Yeah, hidden disabilities can be a big challenge. Not that necessarily it's disability, but yeah, that is another really good piece. Thank you so much. Thanks for being with us for all of these sessions. Thank you for making this really a learning collaborative. You guys have had your cameras on, you've talked, you've shared. I feel like I've learned so much from all of you. I also want to take a minute to thank our hub who's been here for all of our 8 sessions and all of those pieces, and just hope to see you guys again. Like I said, come back next fall and bring a friend or 2 or 3. So take care, everyone, and stay safe.